A lot of things about general surgery and what general surgeons do with that is gallbladders, hernias, but this is a more in-depth about hernias. I feel like hernias are something that we see pretty commonly. Sometimes there are things that need to be fixed and sometimes they're not, and so I kind of just made a presentation about it, and so in case you or anyone you know has something that you're worried about, you can send them my way, or if it's something we don't need to worry about, that's good too. I did have a topic that I think would be a really good topic for a next Lunch and Learn, but I wanted to run it by everybody. I'm going to wait till everyone's done eating, so we'll talk about it. I have another topic I like. We won't talk about it today, but I wanted to get everyone's temperature on it, see if it's something we would want in the future. So anyway, let's get to hernias. Okay, so what is a hernia? If you've ever seen me or talked to me about this, this is kind of how I describe it. It's a hole in our fascia or muscle or the strong stuff that holds us together. The belly is kind of generally where we think about it, and there's a lot of places. And most of the time there's an organ protrusion through that hole in the muscle. Sometimes it can just be fat that's coming through, but the thing we get really concerned about is something coming through that hole. These are kind of normal places. So this is a belly. So you can get belly button hernias are really normal. You can get what we call an incisional hernia, which is if you've had previous surgery and you get a hernia through that scar. Inguinal, which is kind of above our groin line, or femoral, which is under the groin line, some people will get them up kind of above the belly button in the midline. One that's not on here, which is pretty rare, but it kind of would happen in this area where you see incisional hernia, is a really fancy one that we call spigelian hernia. Those are actually really hard to diagnose because instead of just a hole and the muscle comes up, it's almost like there's 3 layers of muscle over this area and they split and everything kind of zigzags through. So they're a little bit harder to diagnose, but that is another type of hernia that we sometimes deal with. And I'll go in, there's a couple others, but I'll go into them a little bit later. So that's kind of some general areas where we would see hernias. And why are they there? So, you know, okay, we'll kind of do this together. So generally, hernias that people get without a surgery happen, belly buttons or groins are the normal areas, and it's an embryologic thing. In our belly button, when you were a baby and you were in your mom's belly, you had the umbilical cord going there, and they cut that off, and it makes your belly button. It used to have a hole where that blood could get to you from your mom. So eventually that generally closes off, but because it wasn't originally closed, it leaves a weak area. So with time, straining, things like that, that little tiny weak area can form back into a hernia. So some little kids, babies, can be born with a hernia. Most of the time we leave those alone until they're about 3 years old, 2 to 3. A lot of times those will close up on their own. If they don't, then it can be something that has to surgically remove. When adults get them, then it's a little bit more serious because it's very unlikely going to close up on its own. The groin I showed you is another area. Typically those happen in men. I have another slide I think that gives more of the percentages, and the reason is another embryologic. When they were developing, the testes start in the belly, and then through development they descend down or come down into the scrotum, and so it leaves behind that potential weakness. So with time, straining, all of that, that area can open up and cause a hernia. Same thing in women, where it's not a common one, but a femoral hernia, because we have our femoral vessels and nerves that go through a tiny hole from our belly down to our leg, and so that can be a potential area for hernias. But these are reasons that we get those. So you have that weakened tissue, and if you do a lot of heavy lifting or you're straining on it, chronic coughing, chronic constipation, overweight, pregnancy is a big risk factor for it, or history of abdominal surgery. Those are all things that can put strain or weaken that muscle, which causes those areas to open up and cause the hole. If anyone has questions, just stop me. We don't have to wait till the end. I'm happy to answer any as we're going through. So this is kind of what a hernia looks like. This is a belly button hernia here. That's a groin hernia. I tried to find the nicest lunch picture I could find of a groin hernia. Again, it's usually a bulge. Sometimes it does go down into their scrotum, but sometimes it just bulges kind of right here in that lower area. This is what they look like from the inside, and I really like to show this because people see the outside and the bulge, but you can see this pink stuff around here and kind of around here. That is the inside of our belly. That's our fascial layer, all that. And then you see the holes here. So all kinds of different hernias there. That's it. If you put a laparoscope in or the robot scope in, that's what it would look like from the inside when we look at hernias. So kind of a cool, I think they're fun to look at that way. So yeah, it's a lot easier to take take pictures that way than it is to take pictures with open surgery. I didn't put any surgery videos. I thought about it and didn't do it today, but and that's what it looks like. What does it feel like? You know, a lot of people say, oh, I think I have a hernia, and some people don't notice, but a lump or a bulge is usually the main thing. Some people will come in with groin pain, and that can be really complicated because pain in your groin can come from your hip, it can come from your spine, it can come from a strain. I used to run half marathons back in the day, and I thought I had a hernia, and then I just kept going, and then thought I had a hernia on the other side, and 6 weeks of physical therapy fixed it because they told me I just wasn't stretching enough, and I just pulled a muscle. So pain is definitely one thing, but usually a lump or a bulge is associated with the pain. Pressure can be in the area, a dull ache or pinching, especially when the hernia is out. So we talked about things coming through the hole. So even if it's not intestine or another organ coming through the hole, a lot of people will get a little fat tissue. I always say that fat tissue is doing its job. It's playing little Dutch boy, and it's there to try to close the hole up so nothing else can get out. And so that's not always a bad thing to have fat in the hernia, but if you put more pressure behind it, that little Dutch boy can't do its job, and then bowel or something gets down there with the hernia. So usually they're worse with activity. I tell people anytime you're increasing the pressure in your belly, so straining, coughing, laughing, anything like that, it's like someone pulled the fire exit and everything in your belly, or the fire alarm, and everything in your belly is trying to get out. So if you're in a movie theater and someone pulls that fire alarm, everyone's rushing for the same area to get out. That's the same thing if you have a weakness in your belly. When you cough or increase that pressure, all your guts and fat are looking for a way out, and that's the easiest way out, and that's why it gets worse with activity or coughing. Fun fact about hernias. So they're a common problem. About 4% of adults get them. 20 million people in the world have them repaired annually. That's a really big number. So again, that's why it's important to talk about. About 1 million repairs each year. I don't know why those are. Anyway, that.
In the United States.
Oh, okay, yeah, sorry. I was like, wait a minute. I did this last week and then I slept over the weekend. Inguinal hernias are probably the most common. About 10% of people will get a hernia sometime in their lifetime. So again, it's one of those things that, you know, there's more than 10 of us here. So I'm sure someone's either had one or will have one. Or maybe not, because Jim's the only man and they are more common than men, but you know. So, okay. What do we do about a hernia? Why is it a problem? So if it's just some fat coming out of it, it may be painful, that's a problem. It may limit your daily activities, that's a problem. But if it gets big where the intestine can come out, then that's a big problem. So we call it incarcerated or strangulated, which all sound like prison terms, but basically it just means that the intestine comes out. Incarcerated means it's stuck, it can't get back in. Strangulated means it spins on itself, and then that cuts off the blood flow to the intestine, which makes it a big emergency. So most of the time when I see people, as long as they're healthy enough to undergo surgery, we do usually recommend surgery because we don't want it to get bigger and bigger and have an emergency where you have to have some of that intestine removed. How do we fix it? So people say, can you just cut my hernia out? And you know, I kind of say, well, I guess we could. But what we'll do is we're going to fix the hole. So I describe it like a hole in your blue jeans. So if you have your favorite pair of blue jeans and you get a hole in the knee, and now it's a fancy thing to do, so nobody fixes them anymore, but back in the day. So what we do is we push everything back in the belly that belongs there. Even that fat that's playing a little Dutch boy, it's a protective fat, and we actually want to keep that in the belly. And if I had a quarter for every time someone told me, well, if you could just take this extra fat, I probably wouldn't be here. I'd be living on the beach somewhere. But no, we don't do that. But the protective inside fat we do put back in, and then we want to close that hole. So just like your jeans, if you took them to the tailor and the tailor just sewed up the hole in your jeans and gave them back to you, and you started wearing them again, the first time you do something, you're going to split that hole back open. And so we don't want that to happen with a hernia. So most of the time we do reinforce it with a mesh. I know everyone's heard terrible things about mesh. There's a lot of things that are terrible that have happened with mesh, but we learn and knock on wood. Generally, mesh is pretty safe for what we're learning. Now, if you've got a big, infected, angry hernia, that mesh is not going to be good for anybody, but if you've got a nice hernia, we're doing it electively, then the chance of something happening with that mesh is really uncommon. I you should have brought a piece of mesh with me. A couple of places have expired ones, and I steal them because we can't put them into patients, and I just bring them so people can feel them. But it's probably with my connector because I didn't see that one. But it's just a synthetic plastic. Some of them are really thick. The one I like to use is pretty thin, but it's strong. And so your body grows in and incorporates that mesh to give you some strength behind that repair. You can do it open, which is just an incision. Usually it's a pretty small incision, either in the groin, the belly button, wherever the hernia is. There are some minimally invasive options. That means little incisions. In my previous life, when I had a robot, that was one of my favorite ways to fix them, is go in with the robot. Laparoscopically, we can fix some of them. The problem is the sewing and the attaching the mesh is a lot harder laparoscopically. It usually requires these little tacks, which look like a staple, but it also kind of looks like a coil, and then they go into the muscle, and people get a lot of pain from that. So typically, if it's a small hernia, I will fix it open. Like I said, invasive is an option, and sometimes I'll tell people I think you should go get this done robotically. Most of the time, we try to help people here where we're at, if that's possible. So other things that we sometimes see is people come to me and they say, well, my doctor said I have a hernia, but I don't feel a hernia. Sometimes people will know what it's called, and sometimes people won't, but this is a different type of a hernia. This is called a hiatal hernia, and it's not a bulge we're going to feel on the outside of our belly. This is more of a hernia where the esophagus goes. So if you look at this picture over here, sorry, it's not very clear, but this is normal. Your esophagus comes down, this little red layer here, that's your diaphragm. So that's splitting, this is the lungs up here, and this is your belly down here. And after your esophagus goes into the belly, that's when it should turn into the stomach. And there's a little stop sign or a valve or a muscle that separates this, that keeps the acid from going back up into the esophagus. So some people will get what we call a hiatal hernia, which just means that this hole in the diaphragm has gotten big, and it allows the stomach to slip up so that you have this muscle now above the belly, and that's when a lot of people get reflux. There are ways to fix this type of hernia. The problem with this type of hernia is it's a little bit different than closing a hole in your belly button. You don't need anything coming out of your belly button anymore. You don't really want anything coming out of your belly button anymore, so we close that hole. With this, your esophagus has to go to your stomach, and that stomach has to keep going. We can't just close the hole. So when I was in residency, this is probably actually my favorite surgery to do. We used to do a surgery where we would pull the stomach back down. We would actually wrap the stomach around itself to kind of help hold it in the belly, and then we would put stitches in that muscle. The problem is usually it's millimeters that you're dealing with. So we would put this tube down the throat that says, okay, I think your esophagus needs to be this big, that tube's there, we put the stitches. But one of three things happened. Either you got it too loose and it didn't help, or you got it too tight and now someone can't swallow, or you got it just right, but in 6 months it loosened up on your own and then you're back. So this surgery is still sometimes done for people if they really have a lot of factors that they need it. Most of the time when people have this type of a hernia, we just treat them with a medication that reduces the acid, like Nexium, Prilosec, Protonix. I would say half of the people in here probably take something like that, because when I see people, almost everyone's on it. So that type of hernia we usually don't fix. So if your doctor sends you to see me about this type of a hernia, you'll usually educate you, but most of the time we won't fix that. The trick is, you can get to this type of hernia, and then this is a little bit more of a problem, because now something, whether it's part of the stomach, or if, I should have gotten a picture from the inside, you can get holes this big in the diaphragm, and your colon can be up in your chest and all of that. That becomes a big problem, because if all that stuff gets stuck in your chest, then we're back to that incarceration, strangulation. So with this, yes, it's sometimes fixed. The problem is usually this happens in people later in life. Their tissues are really weak. There's a million ways to do it. Some people just sew them. Some people put a mesh layer in it. The problem is now you're putting mesh. The heart's like right here, so you don't want to tack your mesh to the heart. Like, there's a lot of issues with those. Most of the time these are fixed. A lot of times they're not diagnosed until people have issues. This is something usually if a person has a big, what we call paraesophageal hernia, which is a type of hiatal hernia, I would send them to a hospital that has a cardiothoracic surgeon, because if a hole in the lung happens or something like that while you're fixing it, they would be able to treat that. So again, in my previous life, that was my favorite surgery, not so much this one. This one takes a lot of time to repair and heal up. So Another thing that is not a hernia that we sometimes see is what we call a diastasis recti. Again, we have a lot of women, I assume a lot of women in here have had children. This is something really, I don't know if you could see, you see this man, he's making his muscle and you get that bulge right there. What happens with the diastasis recti? This comes from pressure in our bellies. In women, it can come from multiple pregnancies, really big babies, pregnancies back to back, like within 12 months. Pushing with a vaginal delivery. With men, I usually tell them this is beer belly disease. You know, it's you get extra strain on that belly and it causes this muscle to separate. So I see a lot of people that are sent to me for this is a hernia. And I actually, it's interesting, my stepmother-in-law, this makes her sound really awful, but she's actually a good person. My stepmother-in-law is a practitioner, so her and I were talking one day and I'm like, how do you guys keep sending these to general surgeons? Like, we don't fix these. And she's like, well, what else do you want me to do with those patients? Like, I want you to teach them about it. And I figured we would teach about it today. So diastasis is a separation of that muscle. If you look at this person, you got your girl with the six-pack. So you see how there's a line down the middle that creates part of that six-pack? This is called your linea alba, and that is just fascia in the middle. So there's no muscle here in the middle. So those muscles are meeting where the fascia is. So with time, this fascia is like a rubber band. If I had given every one of you a rubber band while I'm talking and you pull on it and fling it across the room and stretch it, when I get those rubber bands back, they're not going to look like what I gave you. They're going to be stretched out. Now they still work. I could still put them around paper, but they're not going to be as tight or as effective. That is what happens. So you see six-pack, also still six-pack, but that area is really stretched out. So now when you go to sit up, these muscles are contracting, but this part is not able to contract because there's no muscle there. And it's almost like if you've seen the kids that get the big parachute and they go like this and it goes up and down, that's what this middle is doing, is it's bulging out. So because this is not a hole, your intestine is not going to come out of this. It can be unsightly. Typically this is not painful, like this is not painful, but because you don't have those muscles meeting all the way in the middle, some people can get some back pain from it. Some people can have worsening constipation because when you're trying to go to the bathroom and use your belly muscles, they're not as effective. Those are kind of the main things. Mostly they're just unsightly and people don't like them, especially young pregnant girls that have just had babies and they just want their body back and now they've gotten that. Some plastic surgeons will fix these. We used to, there's a slight period where I did try to fix these. If you had an umbilical hernia, which is medically necessary, we would fix the umbilical hernia and just run the stitch all the way up to pull you back together. But most of the time that tissue is just so weak, it just kind of pops back. So some plastic surgeons will fix them if you're having a tummy tuck or something like that. Most of the time with this, we tell people weight loss, avoid heavy lifting. I will usually send them to a specialized physical therapist because we say you need to increase the muscle strength in your belly, but you don't want to do like crunches and planks and things like that. You want to work more on the muscles behind that, so deep breathing, things like that are increasing those muscles, but not crunches. Crunches actually can make that worse. So, but this is not something we usually fix. Again, I spend a lot of time educating people on why we don't fix it, what it is, why it's not an emergency. In the short term, I usually give them what we call an abdominal binder, which is a big Velcro and elastic girdle. It acts as an external set of belly muscles, and so it helps them to get some relief from those symptoms, but it's not something we surgically repair. So I think that is probably my last slide on hernias. It is. So questions, comments, stories? You guys always have good stories for me. So what can I answer for you? Everyone's clear? You guys are all going to come fix hernias now? Okay, well, I see most people are done eating. Is your stomach sensitive? Are you okay? Okay, so I really, and I'm not prepared to talk about it today, even though we kind of went through that fast, but one thing that I talk to people a lot about, so we do screening colonoscopies, and so I end up talking to people about their poop a lot. And what I've realized in 15 years now, talking to people about their poop is that nobody talks about their poop. So when their poop is abnormal, they don't know it's abnormal because you don't go to church and sit down and say, hey, how's your bowel been this morning? Are you having them every day? Does it look like that? Can you bring a picture for me? So I I think that would be a really good topic, is to talk about normal, abnormal, why we have abnormal, because a lot of women in here typically have abnormal bowel movements, what we can do about it, when to worry about it, when not to worry about it. I think that would be a good lunch talk. Well, I think it would be a good talk. Maybe if we're doing that one on the next Lunch and Learn, we all get here a little early and eat our lunch before. But if everyone's up for it, I think that's something that's really relevant. Again, not everyone here has a hernia, although it's interesting to talk about. That might be something more relevant. I just wanted to feel out the audience and see how we're feeling about poop talk during lunch.
I've had a colon resectioning. I think I'm really going to be interested.
Okay.
I had a hernia. You name it.
You got it. Okay. So yeah, I live in a house.
Too much information.
I told you guys have good stories. I live in a house of all boys, one of which is a 4-year-old. We talk about poop a lot at every meal. Somehow he has to go poop during every meal. So well, I feel like either I hit all the topics, or you guys are hiding questions from me. But.
It was good.